Hello, everyone. It's my great honor to have my talk presented in the annual meeting of Neuro-Ophthalmology Society of Australia. And today I'm talking about an interesting case. This is a 64-year-old male patient who was previously healthy. He presented with an subacute vision loss in the right eye over 3 days. And he had a right side headache for about 1 month before, and he had no trauma. He denied any infective and inflammatory history. There was no audible bruit, but we found intermittent pulsatile proptosis on his right eye, and the patient's vision was cutting finger 1 meter in the right eye and 20/20 in the left eye. The intraocular pressure was normal in both eyes. In his right eye, there was IPD positive and ptosis, generalized ophthalmoparesis, dilated and tortuous episcleral veins. On examination, we found out that the anterior segment was clear without any blood reflux in the Slam canal, and we found no abnormality in the fundoscopy and fluorescein angiography. In the left eye, the patient was normal. The patient was sent to radiology department for further assessment. And in his MRI, we detected the restricted diffusion of the posterior orbital segment of his right optic nerve, suggesting an acute posterior ischemic optic neuropathy. 3D TOF MRA demonstrated the high flow of the right cavernous sinus without any dilated superior ophthalmic vein. We found, and then the patient underwent a DSA procedure, and an indirect CCF was found. The origin of the right ophthalmic artery was visible, but we couldn't see any usual branches of this artery. However, the vascular network of the left side was perfectly normal. The right common carotid artery angiography shows superior ophthalmic vein occlusion and the drainage vein of the CCF running through the inferior petrosal sinus to internal jugular vein. The durocarotid cavernous sinus fistula is a pathologic communication of the arteries and the cavernous sinus. And the duro CCF had the disturbed flow leading to a remodeling process of venous endothelium and the venous arterialization, which could cause the superior ophthalmic vein occlusion. In our patient, the long-lasting ophthalmic vein occlusion could be the reason why the capillary pressure increased, and consequently, the flow of the ophthalmic artery branches decreased. This was similar to the mechanism of ischemic retinal in central retinal vein occlusion. That's why we could explain the angiographic manifestation of the right ophthalmic artery branches. And our hypothesis was the steal phenomenon, in which the blood from ophthalmic artery was stolen through the duro CCF, leading to the reduction of blood supply to the posterior orbital segment of the optic nerve. And in our case, the ophthalmic vein obstruction was overlooked in MRI TOF because of the low flow nature of the duro CCF. And the restriction diffusion in MRI should be differentiated between inflammatory infiltration or infection of the optic nerve. And here in this patient, the differentiation of ischemia was based on focal lesion without any evidence for local or systemic disease to cause infiltration. Duro CCF related ophthalmic vein occlusion and posterior ischemic optic neuropathy are very uncommon. This patient presented with an atypical cavernous sinus syndrome and a subacute vision loss over only more than 1 week. Therefore, any potential fistula should be suspected or taken into account in a patient with unexplained transient vision loss and accompanying signs such as proptosis or dilated episclerovasculature. Last but not least, time-critical nature of the whole process must be seriously considered to preserve the function of the patient. Thank you for listening.